All right. I think let's get started, Chris.
Yep. So, hi everybody. My name is Chris McCann, and I am the Director of Communication, Insight, and Campaigns at Health Watch England. So, I'd like to welcome everyone to this webinar on VacciNation, which is a report we've done alongside Traverse, exploring vaccine confidence with people from African, Bangladeshi, Caribbean, and Pakistani backgrounds living in England. The format of the event will be as follows. Quick welcome and introduction from me. Then Louis and Ewan will do a presentation on the findings, which will take about 20 minutes. Then we have a panel who will give their reflections on what the research has shown. That will consist of Dr. Bola Owolabi, Director of Health Inequalities for NHS England and Improvement. One of the participants in our process, Imani, and one of the facilitators who will give their reflections, Shazia, and Sam Roger from the NHS Race and Health Observatory. And then at the end of the panel discussion, there will be Q&A from the audience, which will give you the opportunity to ask any questions that the findings have raised from yourself. So do keep a mind on any questions you might like to ask as we move through the presentation. So this piece of work came about off the back of work that Health Watch had been doing in terms of gathering the views and experiences of people across England around the COVID-19 vaccine. Since January, the Health Watch network has gathered the experiences from 15,000 people, and overall feedback has been positive, but uptake of the vaccine is still significantly lower among specific communities, and there remain issues of vaccine confidence among groups that are now being targeted to receive the vaccine. Off the back of this, Health Watch England commissioned Traverse to undertake in-depth conversations and online exercises with 95 participants from African, Bangladeshi, Caribbean, and Pakistani ethnicity over a period of 5 weeks in March and April of this year. The engagement research was with people who have primarily hesitant or lack confidence in the vaccine. Testing out a number of hypotheses as to why people are hesitant and what could be to give additional assurance. It's clear from this work that attitudes to the vaccine are incredibly personal, and it's important not to make broad conclusions about the views of whole communities as a result of these findings. So we've therefore taken great care and with some caution pulled out some themes from this very complex piece of research to help the Department of Health and Social Care, NHS England and Improvement, and others to take action. I think it's very important to note that the findings from this work and the way it was undertaken will help provide important lessons that will reach out beyond the COVID-19 vaccination program and can help the work in the longer term as well, as we all work together to tackle health inequalities. So I want to move on to the next slide. So as I said, we've gathered the views of 15,000 people across England about the COVID-19 vaccine and the rollout. And the uptake is still significantly lower among Black and Asian people as opposed to the general population. Health Watch commissioned Traverse to undertake to talk to 95 participants from specifically African, Bangladeshi, and Caribbean and Pakistani ethnicity. Research was with people who lack confidence in vaccines. The attitudes to the vaccine are incredibly personal, and as I said before, it's important not to make broad conclusions about the views of whole communities based on the findings of the individuals that we spoke to as part of this research. So, as I said, the findings from this work are going to be really useful, and as I said, you know, the lessons that we'll be able to learn from it. And the sharing that we've already done with stakeholders, they're already keen to understand more and build on this as we look at how we make sure we reach more seldom heard communities in future programs. So I think at this stage I will hand over to Louis and Ewan, who sort of led on the research, and will take you a run through the findings over the next 20 minutes or so.
Great, thanks, Chris. Just to clarify, so I'm Louis and I work for Traverse, and I've been helping deliver this research. My co-presenter on the findings is going to be Ella, who has also been working with us, just in case you get any confusion when Ella starts talking. So as Chris explained, the context for this research was set against some kind of background work that HealthWatch did, talking to 15,000 people, asking them about their attitudes and opinions on the COVID-19 vaccine. And that gave us a set of hypotheses to work with, which we tested throughout this project. So as you can see on the screen there, so those range from kind of practical barriers. So do people have practical issues with accessing places where testing and vaccination was happening? That could include generational differences. So were some generations more hesitant than older generations when it comes to taking the vaccine? This element of deeper cultural mistrust, amongst others. And these are the kind of hypotheses that we set out to test through this research. The other context and important piece that we realized quite early on when it came to the work is that in the kind of online space where a lot of these conversations are happening about the vaccine, there isn't much room for debate. So when people kind of showed reservations about the vaccine, people often had very strong reactions, whether that was one way or the other. And discussions can become quite negative, and people associating blame and assuming malintent as well. And you can see that reflected in the kind of media coverage as well. And the idea of people who felt that there was positives about the vaccine felt strongly against the kind of opposing sides that we could see. And what we wanted to do through this research is create a safe space for these conversations to take place, for people to share their thoughts, concerns, ideas, and allow for some nuance to occur as well. I'm now going to hand over to, I'm going to talk really briefly about the approach before we get to the exciting stuff. So Chris touched on this briefly. So it was a 5-week project where we had an online panel where people completed online activities individually. And on the bottom there, you can see the research questions that we kind of went through over each week. And then there was 2 online discussions on Zoom with 35 participants each, where essentially the kind of findings that we got during the first 2 weeks were then discussed in more detail during the online group discussions. And you can see that we kind of wanted to start the project with giving people the chance to say where they currently stand with the COVID-19 vaccine in a non-judgmental space. And then finally, the last research question we asked people is kind of what would they do if they were responsible for the vaccine rollout? And that gave us a nice kind of context to understand where people felt when it comes to the vaccine. Right, I'm going to hand over to Ella, who's going to talk through some of the findings.
Morning, everyone. I'm Ella. So what we found is that individuals had a really diverse experience, and as Chris has already mentioned quite a lot, they're not a homogenous group. And our participants really sat along a wide spectrum of views. So you can see on the left there from very extremely negative, so things around, Bill Gates implanting microchips or sort of population control of Black communities, over to actually quite positive views about the vaccine. So, this is the only way out of the pandemic. So even though everybody was recruited on the basis that they held a lack of confidence or some level of hesitancy, actually it was quite nuanced. And most people sat sort of somewhere in the middle. So the quote here on the slide is quite indicative of sort of the most common view that we came across amongst our participants. So I'm not against the COVID-19 vaccine, but I don't feel confident about having it at the moment. And I think that that's quite key. And as we carry on talking through the findings, that will come out a bit more clearly. So if we go to the next slide, Lily. So what was really interesting is that actually targeting Black and Asian people could be quite counterproductive. So there was a feeling of blame attached to targeted messaging, and it's summed up really nicely by the quote here. So I'll just read it out very quickly. So It's like, we're going to put you in this pot and white people in this pot because you're the ones who are dying the most and you're not taking the vaccine, and white people are, and why aren't you taking it? What a load of rubbish. I've just seen a message that the sound is fuzzy. Is it fuzzy for everybody? Can you hear me okay?
I can hear you okay. It could be, is anything like near your microphone or something?
I am going to put my headphones on.
Okay.
Hopefully that's,
Yeah, I think that's much
that's better.
Yeah, thank you.
Okay, great. So yeah, so I was just reading the quote there, which is indicative of how a lot of people felt, and that feeling of blame. So it felt like participants said they were feeling singled out as problem groups, despite not having been consulted either before or during the rollout on how to best reach them. Being front and center of sort of the media pressure as well, emphasizes feelings of judgment, displaying any kind of level of hesitancy or raising ideas around lack of confidence. And linked to this really were the celebrity campaigns, which were seen as pretty patronizing by most of our participants. Why would I listen to a cricketer about the vaccine who has no medical training or background just because they're the same color as me? They really did not land well with the participants in this research. So overall, the kind of extra push and targeting made some participants more suspicious of the motives behind the vaccine. Why is it being pushed to Black and Asian people so explicitly? And the most extreme example of this was one participant describing it as vaccine terrorism, constant media messages, texts from my GP, and seeing messages about the vaccine absolutely everywhere. And ongoing talk of vaccine passports and sort of potential mandatory jabs for healthcare workers, which were in the news, stories in the news as we were undertaking the field work, sort of added to this sort of oppressive feeling overall. Go to the next slide here. So what we've done is we kind of created some top tips in terms of providing additional assurance and increasing confidence in the vaccine. So the first one is about localizing the approach. And this is really about reaching out and engaging communities and really replicating the safe space that we were able to create in this research, so that people feel heard and are able to safely express their feelings, whether that's a lack of confidence or any questions that they might have. The second point or tip, I suppose, was really to deliver messages via people who have a clear connection or lived experience of the vaccine. And linked to that is also people who have a tangible relationship to individuals. So as opposed to any healthcare professional, actually my GP, if the message comes from someone I'm already linked to, that makes a large difference. Number 3 is around clearly communicating why people should have the vaccine. This was not clear to our participants. There was not one clear understanding as to why they should have it. They didn't know. Is it to stay out of hospital? Is it to reduce the spread? Or is it just to stop me getting ill or to stop others getting ill? It's really unclear and hazy. So number 4 is around providing information for unanswered questions. So as one part of the exercise that we conducted with participants was to create a bank of questions that they had. And there were many, many, many questions with no clear answer or possible way to really find a definitive answer to. So, a good start is just recognizing what those questions are and trying to give some information to help answer some of those. Providing clear references to source information in any communication. So participants wanted to fact check for themselves, and they often described doing just that, not simply relying on one source of information. And they wanted to see how they could find out more and correlate what they were seeing and hearing about the vaccine. Number 6, give people the information they need to make the decisions that they feel comfortable with. And this is really linked to the ambiguity that participants felt existed with regard particularly to the long-term impact of the vaccine. People said no one knows what the long-term impact might be. We can't know because it hasn't been out long enough. So can we just actually admit that? They wanted that to be spoken to explicitly. And this was particularly an issue with regard to fertility as a particular concern in terms of long-term impacts. And finally, carefully consider targeted messaging. So it's obviously linked to the last slide. Don't lump people together from different ethnic backgrounds, that they're not all the same. There's lots of nuances and differences. And also rethink the idea of celebrity campaigns in particular. Go to the next slide. Thank you, Louis. So in terms of key actions to increase trustworthiness in public health messaging, we kind of came across sort of 4 core messages really here. So the first one is around agency. So people's sense of agency being pivotal to their decision making, you know, respect their agency. Frankly, those who are spreading misinformation are currently doing a better job of this than the government, because they're saying things like, go and do, don't just believe me, go and do your research, whereas the government messaging has been quite linear, you know, take the vaccine and that's it. So secondly, independence, you know, the independence of institutions and those for whom they speak is really crucial in building trust. So, for example, participants said they trust the NHS. However, they also feel that it's been used as a government mouthpiece on the vaccine. So therefore, that trust is really waned and is starting to be questioned. And they prefer very clear independence, and they distrust also anybody who's potentially going to gain commercially from the vaccine as well. The third one is around transparency. So the more transparent an organisation or information source is, the more trustworthy. You know, participants want to know information on the vaccine is public and accessible, regardless of whether they're actually going to access it or not. They want to know that it is out there, should they want to do more research. And there's also a desire for a range of information sources that can be verified against one another. And finally, in terms of the fourth action to increase trustworthiness, it's about experience. So the more real world experience that an individual has with either COVID-19 or the vaccine, the more reliable they are as a source of information. So participants talked about doing things like joining Facebook groups, whereby people who'd had the vaccine would go on and report any immediate side effects that they experience. They also said that they, you know, trust frontline healthcare workers who are really, you know, they're, you know, doing the work on the front line much more than any senior staff who might be somewhat removed from that. And linked to that, you know, the idea of generic celebrities or even faith leaders who are not linked to them personally are not necessarily trusted for similar reasons. Whereas, you know, perhaps your own imam, for example, your own GP, that it is slightly different and much more impactful than just a kind of overall generic campaign. And finally, we kind of created a quick sort of checklist in relation to tone and format specifically. So I've said it lots of times already, and other people have too, but I'll say it again. Recognise that Black and Asian people are not one homogenous group. Number one, really, really clear finding, came out very, very strongly. Acknowledge there's some ambiguity that exists around the long-term impact, you know, speak to that. It feels as though you're treating people as stupid. That's how participants kind of described it. If you don't admit that there is some ambiguity, recognise the legitimacy in skepticism based on deep-rooted mistrust in institutions, you know, based on experience by Black and Asian people. That needs to be recognised and acknowledged. A conversational format was preferred, you know, allowing some space for questions and for that safe space to sort of play out. Linked to that, you know, overly simplistic messaging, i.e. take the vaccine, is unhelpful and also felt to be quite patronising. Ensure messages are practical and accessible, so providing messaging in multiple languages is definitely important. And ensure that the tone is right by speaking to people rather than at them. Again, don't just say take the vaccine. It needs to be a conversation, and it needs to be inclusive and more kind of collaborative, I suppose. So those are the key findings. There is one quote here which I'll read out quickly just to finish on. So they should be honest and tell the truth. Let people make an informed decision and choice. Stop trying to push people into a corner to take the vaccine. give them the info, be open and honest. If you don't have the info, at least say that you don't, and say the steps you're taking to ensure that there is sufficient info. And also, when it comes to BAME, don't insult our intelligence because we're from BAME and think you can go and get whoever to influence you. What you're saying is we can't think for ourselves, we don't want scientific info, and we will just be swayed by the celebs.
Great, thank you, Ella. I'm just going to quickly run through the kind of breakdown of the participants that we had. So most participants were in the kind of 30 to 49 age bracket. And then in terms of ethnicity, pretty even split between Caribbean and Pakistani, followed by African and then Bangladeshi. In terms of gender, so skewed slightly towards people who are female. And then most people saying that they had some religion or belief. And then in terms of our socioeconomic groups, so majority of people sitting in that C1 group. And then on the right, there is people's attitudes towards the vaccine. So the ones that you see in the kind of purpley red color there is people who are hesitant towards the vaccine. And then people in grey is people who felt confident about it. It's worth noting that from the people who had already received the vaccine, certain people still felt anxious or unsure about the vaccine and the process, despite having taken it. So that's everything. Now I'm going to hand over back to Chris, and I'll just stop sharing my screen.
Thanks, Louis. So we're going to now enter sort of the panel discussion element of it. We're going to go first to Bola, who's the Director of Health Inequalities for NHS England and Improvement. Bola, could you just give us your reflections on the findings from the research?
Thank you so much for the invitation to be here. And I just want to start by saying what an important and timely piece of work Health Watch have done here. I think the insights that have been provided do really give us a firm basis to proceed from as we tackle wider health inequalities. So just some reflections from me, and I'm so sorry that I'm not able to stay for the rest of the meeting. I would have loved to really hear the conversations going forward. But just my reflections on this report. The things that stand out mostly to me are the importance of starting with why. You know, giving people a clear purpose for taking the vaccine. And, you know, that can range anything from the prevention of severe illness, protecting themselves, protecting their families and their communities. And also, as I think about it, avoiding the debilitating impact of long COVID, even among those who are young and may encounter less severe illness from COVID-19 infection. I think there's also the issue of trust, and it's great to see that people do trust the NHS and all the wonderful people working in the NHS providing care and support to people and communities. And I think we can really take heart from that and build from that because, of course, people's agreement travels at the rate of their trust. And so to see that people do trust the NHS and all the wonderful people working incredibly hard across the NHS is a very powerful insight. I also noted the strengths-based approach and how important that is. So giving people timely, accurate information and thus empowering them to make informed choices. That's another observation that I picked up, which is, you know, really taking that strengths-based approach to all of this. I also noted the importance of a hyper-local approach, which is really connecting with and working with the communities directly, because they know how best to reach people and how to have the conversations that really matter. And then in terms of how the NHS can use the findings to reshape the vaccine rollout over the next few months, I do think there is an opportunity to build on the success we've already seen without being complacent. So the report shows the 45-fold increase in uptake in Pakistani and Bangladeshi communities. And I know that we've gone from 38% uptake in Black African communities to around 70% in the latest data that we have. So, you know, we are making progress, and I think we should be building on the success of that. And like I said before, that highly localized approach, enlisting the support of GPs, social workers, community leaders, faith leaders, you know, people with whom local communities have established personal relationships of trust, is incredibly important. And I think we also need to directly address the unanswered questions identified in this report and communicate those answers clearly, consistently, and in language that is meaningful to the communities that we're addressing. In other words, communication that is culturally competent. And my takeaways are, in terms of engagement to tackle health inequalities in future. One, in tackling health inequalities, it is important that we harness and mobilize the relationships, the partnerships, and the networks that we've established as part of the pandemic response in getting the wider message around health inequalities across to our communities. Secondly, I think it's important to take a lessons learned approach by proactively looking at what has worked during this pandemic response generally and the vaccine rollout specifically. And then we build on those lessons learned as we now work to tackle wider health inequalities. And for me, I'm going to conclude on why it's important that HealthWatch, as the national champion for patients and care users, should be placing emphasis on health inequalities. My sense is, given that health inequalities is the greatest legacy that we can leave beyond this pandemic, it is of vital importance that HealthWatch, as the body with a statutory duty to represent the voices of people and communities, places tackling health inequalities as a key strategic priority and objective, and works with us in the NHS in engaging our communities, taking that hyper-local approach that I talked about before, to deliver that vision of providing exceptional quality healthcare for all by ensuring equitable access, excellent experience, and optimal outcomes as we address health inequalities. Thank you.
Thanks very much for that contribution, Bola. I know your time is very precious, so thanks for taking the time out to join us this morning. And certainly we recognise and echo your sense that HealthWatch has a real role to play in sort of having a focus on equalities, diversity, and inclusion within our work. Particularly that issue you talk about of equality of access and equality of outcomes from people's experiences with health and social care services. So thanks very much for your time. As I said, I know you have to rush.
Thank you. Thanks very much.
So this takes us on then. I think this will be a really useful insight, is hearing from one of the participants who took part in the research. I think we're going to go to Imani now, who, if they're available.
Yeah, I'm not sure if they managed to join. They said they were having tech issues. Imani, are you there? I think if not, Well, let's move on and see if she manages to join afterwards.
Okay. Hopefully we'll get them linked in. That takes us then to Shazia, who was one of the facilitators. Shazia, can you give us your reflections on how it felt to be participating in this project as a facilitator?
Thank you, Chris. Yes, it is a project that's tackling some very important questions, and it was great to be involved with the project and the conversations and be part of the team, however small a part it was, but it was great to be a part of the team. I was just reading through some of the comments in the chat as well, and I suppose I'll just sort of, in terms of my reflections, tap into some of the questions about how we reached out to the different people and the people and the sample that we spoke with. And one of the important things to highlight, and you know, this was something that was discussed as a team, all of us working on the project, was to ensure that the research was inclusive, and that we ensured that we spoke to as many people and had those conversations. And I know in terms of the approach, we've referenced the fact that there was an online survey and online platform. We had the online groups, but there was also an element of the research where we actually had telephone conversations with people to actually ensure that those who might be digitally excluded, may not have access to that platform, or just didn't feel as comfortable, were able to still have their opinions viewed and shared and be able to have the conversation. And I keep using the word conversation, and I know that's been sort of referenced a number of times already, but it's important to sort of take it back to, I suppose, the way we went about doing the project, and ensure that it was a conversation, that participants felt comfortable, felt that it was a safe space where they could speak. And those telephone conversations allowed for people to, if they had language barriers, for example, and that's one of the insights and findings and tips that Ella was talking about earlier, ensuring comms are in the different languages. We were aware of that and ensured that if people didn't feel comfortable having the interview in English, that we were able to allow them to talk to us in their own sort of language if they wanted to speak with somebody who might want to speak in Urdu or Punjabi. That was available. So the flexibility of the approach and the telephone conversations did allow for that. And a lot of that did fall out sort of quite naturally in terms of, if people did request that, then that was definitely there. And I think that's sort of really important to highlight, again, allowing people to be able to sort of speak and have their opinions shared. And one of the things I suppose I'd like to sort of reference as a facilitator and being involved with this project was at the end of some of those conversations, the number of people that were actually genuinely thankful for having their opinions heard. And I think this is a great insight for us as well, and highlights the importance of these types of projects, that not everybody always gets asked their opinion. And, you know, as people who work within research, you know, talk about these topics day in, day out, we forget that, you know, there's probably people out there who've never been asked what they think about the vaccine. How do they feel about it? So actually allowing mechanisms like this and opportunities for people to voice their opinions, it's really important to do that. And it does actually sort of allow people to to think a little bit more clearly and just be able to voice their opinions. And I think it's sort of, you know, we are moving quite a way in terms of actually allowing people to do that, but there's still quite a lot to do. There is trust involved with, again, in terms of recruitment of the people taking part in research projects. People who aren't familiar may need that little bit more sort of reassurance of, well, you know, this is a genuine project. We really genuinely want to hear your opinions. So there is still quite a lot that we need to do on that. But in terms of this particular study, we did allow and have those telephone conversations, and it was really helpful and important to have that available. Sorry, I'm trying to read some of the comments as well. I'm not very good at sort of doing that at the same time. But that was sort of the main thing that I wanted to sort of highlight, really, in terms of actually making sure that we had a range of different people. And what that does is it allows us to pull out the nuances, which we wanted to do with this research project. And also fits in with that point that, you know, a number of people have made already, is the fact that it isn't just one homogenous group. We want to understand people's journeys throughout this process. You know, what are the different elements that feed into their opinion as it is now, and what more do they need in terms of actually sort of being able to make a more informed decision moving forwards, whether that's to do with the vaccine and other things which might be sort of health related, but specifically with this project with regards to the vaccine, which is why looking at those networks and the people that they're interacting with did come out quite strongly. So the conversations that they're then having with people that they know quite well, hence, you know, if it's somebody that's part of that local community, it's important, rather than somebody who's sort of quite removed and they can't relate to, for example, a celebrity. So actually hearing from people who are more like them in terms of people from the community. Thank you.
Thanks, Shazia. I think that point about trust is something that keeps coming through, and that there needs to be realization that building trust isn't going to, it's not a quick process. You know, it needs to be earned, and the only way we can do that is to engage with people, to listen to their concerns, and sort of talk through what their ideas for change are. You know, and recognizing that communities have very good reasons historically for having a lack of trust in institutions. No, I think that was a message that has come through very strongly, and one that needs to be listened to. So the final member of our panel discussion is Sam Roger from the NHS Race and Health Observatory. Sam, interested to have your reflections on the report and also what you've heard this morning.
Yeah, thanks very much, Chris. And hi, everyone. As Chris says, my name's Sam Roger. I'm the Policy and Strategy Lead at the NHS Race and Health Observatory. We're quite new, so I'll just very quickly introduce what that is, just so people are aware. We are a new NHS-funded organisation set up to commission new research and gather evidence on ethnic inequalities in health and care across the country. Our role is about bringing that research together, turning the findings into actionable recommendations. And then importantly, because we are a publicly funded body, our role is not then just to put the research out there and sit on the sidelines and wait, but actually to get quite directly involved in the implementation of change by working directly with Bola and team, as well as others across the system. And so we were incredibly happy to be invited to collaborate with Health Watch England and Traverse on this project, giving our support and advice as we could, though I don't want to take too much credit and detract from the excellent work they've done and that we've seen today. I won't speak for too long, because I think it'd be good to get into some questions, but I wanted to pick out a couple of the main things from the findings and the conversation that have really struck me. The first is really about empowerment and agency. And I think in a year where everyone's freedoms have been so limited in so many ways, it's no surprise that people crave agency. And as was said in the presentation, I think when misinformation does spread in the internet or through whatever means, it often comes with this empowering message of do your own research, engage with the facts for yourself, don't just be spoken at, but make up your mind based on what you see. And that is very empowering. That makes people feel like they have some control over their bodies. And I think it's easy to forget with something like vaccination, is that it's invasive and, you know, it's intrusive and it's your body. And I think people want to have the power to make decisions about that. And linked to that is this point about pressure and the sensation of pressure from large institutions. And I think pressure without transparency necessarily leads to suspicion, and that's what I think we've seen in the findings of this report. People should be trusted to make decisions based on the information. We at the Observatory have been doing a piece of work alongside this one, looking particularly at vaccine hesitancy among the health and care workforce. And what was found there in many instances was that when you're put under pressure to do something by your employer in this instance, you're actually much less likely to want to do it. Because when information is hidden from you, you start to suspect the motives of the people putting that pressure on. And I think the most important thing, this is something that mentioned, is trust. And it was particularly striking to me, I think, to note that of all the sources of information listed in the survey, the government was the least trustworthy source. And that's quite striking, really, especially during a public health crisis. The government is really someone you want people to be able to look to for information they can really trust and make decisions based on. And there's many causes of that lack of trust, whether you look at the recent handling of the pandemic, for example, or what's seen as changing advice over the course of the vaccine rollout. But I think what we see at the Observatory is that lack of trust also speaks to something much deeper and longer term. And that's the fact that some communities, especially Black and Asian communities, don't feel that these government institutions necessarily serve their best interests. And it's built upon years, maybe decades of experiences of discrimination, experiences of inequality and systemic racism that can span generations. And I think Bolo made a good point about the fact that while we do need to build that trust up, we're not starting from zero. What this research showed is that NHS institutions and especially medical professionals are trusted already. And actually what we need to start doing is not patronizing people who are very legitimately hesitant about having a vaccine they know little about, but engaging with them on the basis of evidence, allowing them to speak with and interrogate medical professionals and actually go to the source and build on the trust they already have. So I will only speak for another moment or so, but just to kind of conclude on where we go from here. And I think one thing to be taken from this research is a lot of the short-term, incredibly practical things that can be done now. So inevitably, with new variants arising, this vaccination program is not going to be a one-off. We'll need boosters before long, and who knows, in future years, we may need other vaccines to cope with new variants. So there's a really important thing to take care about the practical steps, the language barriers, the transport barriers, you know, where we're actually in the communities, where the vaccines are being delivered. But the much more long-term challenge is about rebuilding public trust. And I think this is where certainly we as the Observatory see ourselves having a role in creating evidence on which we can base that. But it's also about the government and other national institutions not taking compliance or trust for granted, engaging in genuine participatory community engagement, and involving people in policy making from an early stage. You know, we all know that COVID-19 was a crisis, but we also know that when there is a crisis and things need to happen quickly, that's often when qualities are left by the wayside, and that's just not an acceptable way of creating policy. So we need to make sure we're keeping that at the center of our minds going forward. I'll stop there, Chris. Thank you.
Thanks, Sam. Again, that point of trust is the one that keeps coming across, I think, and the importance of engaging with people in a way that deepens our understanding of the issues that they're faced, you know, and fears that may be based on previous lived experiences, and the need to provide them with straightforward information from people they trust is one that I think that's a really powerful message. So I think we're going to go now. I think the team in the background have been collecting questions from the chat.
We have indeed, Chris. I'm just going to turn my video on. Yeah. So I think Jesse, you come in as other questions as well if you wish, but I'm just going to read out a couple from the chat to start with, and Chris, feel free to feed them out to the panel and to Louis and Ella as well. So I think the first was quite a practical question about whether we're able to draw out any particular findings from the younger participants, so the 18 to 29-year-olds, and took part in the research with a view to that particularly shaping the comms and engagement over the next few weeks of the vaccine campaign. And I'll give you one more to work with for the moment. So I think, yeah, the other one is a couple of comments about actually that this isn't just an issue for Black and Asian and minority ethnic groups, that there are significant proportion of white British people who have hesitant attitudes towards the vaccine, and actually what need is there for research in that space, and I suppose what can we learn from this research we can apply to that group as well. So if I don't know if we've got any takers of those, but I'll leave you those for the moment. Other people, if you want to put questions in the chat, keep doing so, and Jesse and I will read them as they come in.
Maybe Shazia, who is somebody who was involved as the facilitation, have you any thoughts on that issue around the 18 to 29 age group and their attitudes and how best we can reach them?
I'm looking at Louis to see if Louis wants to answer that one or not. I suppose from some of the conversations that I had, we did explore the generational hypotheses, and it was very interesting because it didn't sort of, you know, for the conversations that I had, I didn't feel that there was a distinct thing coming through, whether it, you know, because you're younger or part of this particular age group, that people thought a certain way. It was, you know, there were a few comments that were coming through from some people where they were saying that, you know, my parents are using more herbal remedies and things like that, or, you know, I'm more likely to you know, to take medication if I fall ill and things like that. But again, it wasn't distinct because, again, you know, we're not looking at homogenous groups. It was more about who else was part of their household, what other considerations they had to sort of factor in, a little bit more about the community that they were in. I don't know, Louis, if you sort of agree with that, but I didn't feel that there was anything sort of that was quite distinct.
Well, yeah, and Ella, jump in with this as well. But I think and there's some more work to do in the data, because people shared with us sources of information that they've been receiving, which has influenced their opinions on the vaccine. And I think there might be something around younger people's opinions and views are being shaped by maybe a broader sources of information. For example, people sharing videos that they receive from America, whether that would be pro or against taking the vaccine. So I think that might be one of the issues that we're seeing. But in terms of that, cultural mistrust in institutions seems pretty evenly spread, and the kind of people not being keen on having celebrities wheeled out, that was also very uniform. So those key findings, I think, are multi-generational.
I suppose I just wanted to add, in terms of the groups that we did actually sort of speak to groups based on, I'm trying to think, the first wave we did have a specific group where I spoke with people who were all Pakistani or Pakistani Muslim. And when we did do the next wave of groups, we did actually sort of take that out, because, again, just to go back to one of the questions that was raised, that there weren't any sort of specific differences coming through based on faith-based or ethnicity. It was more about the experiences. So the groups were actually sort of integrated a lot more rather than actually separated out. And again, really interesting point there about some of the comms that are out there, which are very targeted, can come across as being quite discriminatory as well. And I think that's a really important point to raise, which is why partway through with our research as well, we did change the format of the way we had the sample within the groups to make sure that it was more generic, and we had different conversations happening within those groups.
Yeah. I just wanted to quickly come in and speak to the point about replicating the research within white communities. Absolutely, I think that would be fascinating to do, and something that we as a team certainly talked about internally. So NASA, great point to make there in the chat, and it would be interesting. Yeah, I think a lot of the findings from this research probably would cross over, actually, with regard to more generally, you know, also white communities who are displaying sort of hesitancy or a lack of confidence, but it would certainly be really fascinating. I think important to also speak to those communities to see how those findings do match up, where they intersect, and perhaps, you know, if there is any diversion at all.
One of the findings that was more relevant based on that kind of 18 to 29 or 35 age group was any questions that people had about the impact on fertility of the vaccine. But apart from that, yeah, corroborate what everyone else has said.
So I'm just trying to pick up stuff now from the chat, and we seem to have covered most of it. That's one of the things that people are is that we seem to have moved on from that. There's also a different strand of hesitancy where people have hesitancy over the type of vaccine, particularly the AstraZeneca. Imagine, did we pick that up at all in our research? Because I think some of it was going on at the time when particularly the stories about blood clots, etc., was hitting the media.
Yeah, so one of the good things about the way we delivered this project is that it was very iterative. So as elements were coming in to the media, or as people shared information that could influence the way they feel about the vaccine, we were able to have a look at those. And it was very interesting seeing people have quite strong opinions about the different brands of the vaccine as they came up. But the same kind of attitudes or the same influence of misinformation and mistrust impacted people's views regardless of what was going on in the media. So if, for example, news about AstraZeneca came up, it just was a kind of microcosm of, well, what's this information mean? What does this statistics mean? Is it going to affect me more, someone who might be Black or Asian? So the same challenges came up kind of almost regardless of the different brands or news articles that came up as well.
And then I suppose in terms of the sort of more broader messaging, I thought that was a very interesting finding about the fact that people didn't like having messages pushed to them by celebrities, you know. And I know when I shared that with sort of stakeholder colleagues last week, they found that a really interesting thing to pick up and something that they'll be looking at as they move ahead. Anything to say about that, about who the trusted sources of information that should be being used are, and I suppose it speaks to that sort of hyper-locality that we've been spoken about.
Yeah, someone else jump in, but my quick thoughts on it is that the celebrity falls into the kind of worst of both worlds. So if people are trusted sources of information is expertise, or trusted information is someone who they can relate to, who they might have exposure to on a regular basis in their daily life, someone within their community, actually the celebrity is neither of those things. So the celebrity is not going to have a medical background necessarily, is not going to be seen as a source of expertise from a kind of clinical perspective. And then from a developing trust perspective, a lot of people can't necessarily relate to a celebrity in terms of the challenges that face them on a daily basis.
Also, I think linked to that, something that's quite interesting that we found in the sort of second wave of discussion groups that we conducted. It was around Ramadan, and we tested a video. We shared a video that had been circulating where Islamic faith leaders were talking about getting the vaccine and really promoting it, and asked participants' opinions on that. And what we found actually is that, again, the response was not that positive. And the comments that we had coming back were things like, well, I didn't see at Easter time a lot of Christian faith leaders kind of really pushing the vaccine, so why is this, what's going on here? Again, it's linked to the points around the celebrity piece as well, I think.
And then in terms of the learnings what do you think have been the key learnings in terms of good practice that we have seen? Has anybody encountered any particularly sort of specific examples of good practice where the message has been got across in a way that communities have found constructive and informative and helpful?
Yeah.
Sorry.
Yeah, go for it.
Can I just jump in? Hi, everyone. I'm Ewan, research analyst at Healthwatch England. So to very quickly speak to those two questions, people sort of tended to wrap up the idea of trust with intangibility. So people that they felt they had a tangible link to. So for example, local GP, their local healthcare worker, they really seem to trust, as well as family and friends, people they go out, they'll see every day, they'll have conversations with them, but also people who have a tangible link to the vaccine rollout itself. So, you know, maybe a nurse who's going out and giving the vaccine every day. And those are the best people to deliver these kind of messages. So some local Health Watch have been doing events with community groups. For example, Health Watch Rotherham did one with asylum seekers, and those kind of events where you get a panel with local nurses, local healthcare workers, they can really, really change people's opinions about the vaccine.
Yeah, that seems to be a really key message, isn't it? It's it's about those local trusted sources. So I think we're starting to wrap up now, isn't it? It's due to finish at 11:30. Has any questions from the audience coming in there that I've missed? I've been trying to keep an eye on the chat.
Pretty much covered most of them. Any that we've missed, we can pick up on and make sure we come back to people with some shared responses as well.
And I'll just encourage everybody to read the report in full. It covers a lot more than we've managed to cover today.
And for those people who haven't had the report, haven't seen the full report, can we just point them to exactly where they can download it from? We'll put it into the chat, I think.
Yeah, it's gone into the chat earlier, but we'll post it again now, so it's right at the bottom and everybody can get it.
Okay, well, if we've no further questions, that is us just hitting 11:30 on the dot. So I'd like to thank everybody who came along to participate in the webinar, both from an audience side, our panel members, the team from Traverse, and also the team from Health Watch England who put this piece of work together. As I said, we think that there are real sort of long-term lessons to be learned from this, which will be useful for a range of stakeholders and organizations as we move forward, well beyond the work on COVID-19 vaccination. So I think at this stage we can bring the session to a close. But I'm sure if anybody has any further questions, all our contact details will be available if anybody wants to find out anything more about the research or the report or our findings. So thanks very much, everybody.